online mode, right?
Very good evening, sir.
Good evening, madam.
Good evening, all. And this is Dr. Chandramohan, musculoskeletal physiotherapist from India. On behalf of Exercise Testing and Prescription Organization, we welcome all our registered participants from United Kingdom, Canada, Kenya, Saudi Arabia, Rwanda, Kuwait, Sri Lanka, Pakistan, Bangladesh, UAE, Nigeria, USA, Sudan, Philippines, Malaysia, Nepal, Egypt, and many states of our nation, India. So there are more than 600 participants for this program. And today's topic is musculoskeletal assessment, which will be taken by Dr. Arun Balasubramaniam. Before we move on to introduction of our speaker, there is a special message for him and of course for the team ExRx India. So this is from Dr. Annapurna Firozabad. Thank you so much, team ExRx India. For giving me valuable knowledge for preparation of Masters in Physiotherapy entrance exam. And special thanks to Arun Balasubramaniam sir. His effort really helped me to clear Masters exam in Government University because of sir concepts of biomechanics and teaching of exercise therapy is very clear. Really knowledgeable sessions done by you, sir. Thanks a lot being there and always supporting and giving your guidance. Recently, I am selected in Master of Physiotherapy Sports in CSJMU University, Kanpur, which is the one of the best university of UP. The benefit of attending PGET every class includes not missing any important material, thinking more clearly about the course topics, developing concepts, and being better prepared for the MPT entrance exam, and of course for MPT also. And this is from Dr. Annapurna Firozabad. And apart from her, there were 80 other attendees, and many of them have cleared their entrance exams in topmost universities and got seats for MPT. And this was from our free classes organized for more than 2 or 3 months regarding the PGET post-graduation entrance test. And now about our speaker, Dr. B. Arun is currently working as a physiotherapist, grade 2 in Government District Headquarters Hospital, Erode, Tamil Nadu. Previously, he was the principal of KG College of Physiotherapy, Coimbatore, affiliated with Tamil Nadu Dr. MGR Medical University, Chennai. He was the lecturer in MAHSA, Malaysia too. He has been a resource person and panelist for many professional conferences and workshops. He has organized various national level conferences, hands-on workshops, symposiums, seminars, and CME in physiotherapy for the last 18 years. He has presented different research papers at national and international conferences. He has published more than 50 plus research articles in national and international journals. Apart from that, 2 valuable things he has done. He has published 2 books entitled MCQ in Physiotherapy with AIT BS Publishers and MCQ in Biomechanics and Applied Anatomy with JP Publishers. He also contributed 1 chapter in Advanced Techniques in Physiotherapy and Occupational Therapy in JP Publishers University, Malaysia. And he is the recipient of Best Teacher Award by KG Foundations, Wales Institute of Higher Education, and Christian College of Physiotherapy for his noble teaching. And of course, beyond this, I have enjoyed his lectures during PGET sessions. The man who clears the doubt while speaking itself, he will type the answer and sending the messages. Multi-talented, and that was wonderful sessions those times. Thank you, sir, and we are welcoming you for the session.
Thank you very much, Chandra, for the detailed introduction.
Yes, sir.
Honored to be a part of exercise testing and prescription team. It was very happy to be travel with you for the past 1 year. I have enjoyed the sessions of the various other elite speakers who have participated in the ExRxIndia. But because of Chandra only wanted me to do the MCQ, since he might saw my book and he has invited me. I think that session we have created around 2000 questions, including starting from the musculoskeletal, the exercise therapy, electrotherapy, and biomechanics, which would be helpful for all of the students. Right, without wasting much time, we will go into the today's session is about musculoskeletal assessment. Right, shall we start, sir?
Yes, sir.
Yes,
Please
sir, please
start.
start, sir.
Yes. Yeah, very good morning and good evening to one and all who gathered here, and I'm very happy to be a part of the today's session. And the musculoskeletal assessment is one of the important part of a physiotherapist who are supposed to be a good physiotherapist. Before, when I completed 2 decades back, we are not focused on any of the assessment techniques, or our teachers are not well taught about the assessment techniques for us. But nowadays, the students are supposed to learn the assessment techniques, and they have to be a wonderful practitioner by doing a clear assessment and to identify what is the condition they are going to treat it. Right? So thank you very much, Chandra, and the whole team for giving me an opportunity, and we'll go on to the slides. Although here I'm going to tell you there are a lot of words in the slides and which make you to sleep, but I hope I'll take this as a little interesting. So this is a common reference letter which I received when I completed my undergraduate degree 2 decades back, like 2000. I worked in a small clinic, and the doctor who referred me as a patient comes with a cervical pain, give him ICT, IFT. So when I was a young therapist and a junior most therapist in the clinic, I did not know what to do. Okay, if it is ICT, means give him traction. IFT is put him the IFT and set the 4-pole electrodes and then just switch on the equipment. Like a technician, I just do the work what was repeated by the doctors or the senior physiotherapists. But later on, when I started reading post-graduation and I started reading the textbook, I was learned what is cervical pain, because when we say cervical pain, the cervical pain occurs because of multiple reasons. It is not because of only one reason, like because of spondylosis, spondylolisthesis, cervical rib, posterior intervertebral disc prolapse, neck muscle strain, trapezius spasm, fracture, right neck, mechanical neck pain, brachial plexus, and so on. So can we give same treatment for all the conditions? Certainly no, right? Because each and every condition has to be dealt with different techniques. For example, cervical spondylosis, you may have applied intermittent cervical traction, maybe they have an impingement in the nerve. But spondylosis traction is totally contraindicated. Same for cervical rib, traction is not at all working. But when we defaultly follow someone's method without giving a proper assessment, then the treatment what we are giving is not the appropriate treatment. So we have to identify what is the cause of the pain, and then we have to do the treatment. Are we focus on signs and symptoms? No, we are supposed to focus on the causative factors, right? So you have to identify different cause for the pain, or different cause for the symptoms, different cause for the dysfunction. Then you have to work on the causative factors, because the signs and symptoms are like viral infection, you have get fever. So only medicine for the fever doesn't cure it. When you kill the bacteria, kill the virus only, the fever will go up. Same like that, if a patient with a disc prolapse, until unless the disc was treated, until unless the muscle was treated, until unless the biomechanics was corrected, the pain will not subside. Maybe the pain subside is temporary. So you are supposed to focus on the causative factors, not on the signs and symptoms. That's what we have to do a clear assessment. A complete assessment is required of a thorough and systematic examination. You have to do a clear assessment, and a systematic examination has to be done for the understanding of the conditions. So to go for appropriate diagnosis, you should have a knowledge of functional anatomy. You should have a knowledge of anatomy is mandatory. You should know the patient history. History of the patient should be known, because most of the conditions which we are going to diagnose are based on the history of the patient. You should have good observation skills to observe whether patient have what else the problem is, what are the symptoms they are explaining, whether his symptoms are matching with the signs. That and all can be done by observation. Thorough examination should be done. What are the prerequisites for doing a assessment? First and foremost is you should have a good knowledge of anatomy. At least you should have a basic knowledge. You should know we have 7 cervical spine, 12 thoracic spine, 5 lumbar spine. Without that, we are not able to do a clear assessment. Without that, you are not able to come and tell that this is the problem he has. He has a levator muscle involvement. He has a biceps tendinitis. He has a supraspinatus hip hinge syndrome. We cannot say you don't have any anatomical knowledge. Second one is we should be aware of the clinical conditions, the signs and symptoms, because the cervical pain, as we saw, the cervical rib also has the same symptoms, or any vascular compression also has got the same symptoms, or the cervical spondylosis may also have the same symptoms, radiating pain. But you should know the radiating pain is because of the disc, or because of the muscle, or because of the nerve. So that has to be understood by the therapist who are going to do an assessment. You should know the mechanism of injury, how this injury happened. That has to be got from the patient history. History of the patient is very, very important. You should get the history of the patient, then understand how the injury happens. Then you should know the palpation skills. You have to know where you are palpating. You are palpating the bone, you are palpating the muscle, or you are palpating the ligaments, you are palpating what structure you are going to palpate. That you have to know. Whether it is abdominal structure or the normal structure. Is it a bone or is it a myositis? It's the osteopathy. That you have to understand clearly. Provocative tests or special tests are very, very important. At least every therapist who are coming out of the 4.5 years program should know 2 tests for each and every condition. Without knowing the special tests, we are not able to do a good practice and we are not able to go for an appropriate diagnosis. The investigations, although you have knowledge or not having knowledge, at least you should have basic knowledge of reading X-ray or checking the values of laboratory investigations. But nowadays, laboratory investigations are very easy because the lab values, the comparative lab values are given on the sideboards for most of the tests. So it is not difficult for a learner or a literate to compare the values. But as a therapist, we are supposed to understand what is the effect on increasing of this. If it is a rise of the calcium, what will be there? If it is more ESR, what is there? That the basic knowledge we should have. Right. So basically, our assessment will fall on the 4 categories. SOAP format: subjective, objective, assessment, and plan. So what we are going to see in the today's lecture is full of this SOAP format only. So what is subjective? Whatever the subject speaks, whatever you getting from the subject is called a subjective assessment, like the demographic data, the data of the history, and the pain history. Pain history is very important. We are supposed to get only from the patient because we cannot assess the pain. The patient subjective assessment is the pain. So you should know what are the things you are going to get from the patient so that we are going to construct the next objective. Once we are able to get all the history and the essential data, that is very easy for us to construct the objective measures. What are the objective? Objective is what a therapist identifies, like the examination skills, the observation skills, the palpation skills, the special test. All these are objectives what a therapist is going to do. Subjective is what we get from the subject, that is the patient. Objective is what I am going to do with the patient, right? So, on the assessment and the plan. The first and foremost is the subjective assessment is the demographic data. So, name of the patient, we should know that to know that this is the correct patients who are going to treat. Especially, I work in the government sector, and in the IP, when I visit the inpatient department like male medical ward, when I say a name, for example, it is a money. The 2 or 3 money will be there. So we have to identify which money I'm going to treat it. So maybe the 2 money have the same initials, same conditions. Maybe 1 money was referred to me, other money was not referred. Okay, fracture tibia, which was IM nail. The first day 1, they are not referred for day 1. Maybe the day 2 only they refer. So I have to make sure that this fellow is my patient. this is not my patient. So that for that you have to understand the data. Age is age-related conditions we are supposed to understand. For example, if a adolescent boy having a knee pain, it is maybe because of some injury in the epiphyseal area, or the same 20 years old sports player having a knee pain is because of the ligament strain or a muscle injuries. If it is a 55-year, 60-year-old patient having a knee pain, it is maybe because of degeneration. So depends on the age also, we are able to identify what may be the conditions. Right? So disc prolapse is uncommon for an elderly patient. So elderly patient like 70 years old patient comes with a back pain, may not be a disc problem, but a 30-year-old patient comes with a low back pain may have a discal problem. So the age may be an important factor to understand what type of disease is. Then the third thing is sex. Some diseases are very common in males, some diseases are very common in females. For example, ankylosing spondylitis, when a patient, 40-year-old patient, 50-year-old patient comes with a complaint of pain in the SI joint, and a male patient, first and foremost, we have to think about is the ankylosing spondylitis. The patient may have a ankylosis of the joint. So we have to be very careful on that patient. Maybe the female is very 10:1 is the ratio. The female is very negligibly affected. Occupation related diseases are very common, especially if the patient is a computer worker and comes with a pain in the wrist joint. Mostly it is a carpal tunnel syndrome, or a patient with a housewife comes with the elbow pain. You can see that and the history says that I was not able to do squeezing, I was not able to cleaning the vessels. Of course, maybe a tennis elbow, right? So based on the occupation, based on his work, we are able to identify it. This is for communication. The chief complaints has to be written in the patient own language. You are not supposed to write patient have a OANE. So whereas you are supposed to write what is the difficulty of the patient. Patient was unable to squat. Patient was unable to wear the shirt. Patient was unable to lift the hand. Patient was unable to walk. So that is the chief complaints which has to be written in the patient's own language. Although some patients are very clever and they have took multiple treatment and they are able to tell that, sir, I have COPD, sir, I have asthma, sir, I have rheumatoid arthritis, sir. But although when we are doing assessment, we are not supposed to write patient have a rheumatoid arthritis, patient have an ankylosing spondylitis. We are supposed to write only the patient words. That is the non-scientific term. The next important thing is we are supposed to understand the mechanism of injury. What type of injury the patient has got, whether it is a micro trauma or a macro trauma. It's a bigger injury or a smaller injury. Micro trauma occurs because of two reasons. One is the sudden onset or insidious onset. So gradually, I have developed neck pain. Gradually, it increases and causes severe neck pain. Or suddenly, when I slept and wake up and got severe neck pain. So there may be a sudden onset or insidious onset. Macro trauma is sudden fall or trauma is called as macro trauma. So macro trauma mostly causes any fractures or ligament injuries, whereas micro trauma causes more of strain or strains. Right. We are also asked about what are the symptoms that bother the patient, where the pain and other symptoms the patient first complains. Sometimes the patient may have referred pain or radiating pain. Patient, you have to ask where the pain started. So that will give you a clue of where the injury happens. Sometimes patient may have, I have only shoulder problem, but actually the problem is at the cervical spine. Actually problem is at the muscle trapezius spasm. But the patient exhibits pain only in the shoulder because the shoulder pain was more. So we have to ask the question to the patient where the patient has a first complaints. The next important thing what we are going to do from the demographic data is history. When we look at the history, we divide the history, we get his story. That is, we are going to get the story of the patient. So whatever the stories we are getting, we are able to diagnose it. 75% of the diagnosis can be made by listening to the history of the patient. Getting a proper history gives you a lot of information. For example, if a patient says that I am working in asbestos factory, then the patient has a difficulty in breathing. You can say it is asbestosis. Or if the patient says that I am a chronic smoker, then you can say he may be having a COPD, chronic obstructive pulmonary disorders. Or the patient says that I am working as a policeman standing for a longer time. He may have a knee problem, he may have a plantar fasciitis. So based on the history, at least 75% we are able to understand the patient have this problem. In the history, what we are going to do is listening to the patient makes a correct diagnosis. Nothing asking questions, just listen to the patient. You can just listen to the patient, whatever the history he says, we are able to make an appropriate diagnosis. No subject areas should be skipped. Every areas we are supposed to listen, has to be listened carefully. Repetition, you can ask the patient to do a lot of times, the patient tell that. You can get information from the patient, makes you familiar. Unusual deviations should be avoided and carefully we have to tell you, because sometimes the patient may say, sir, I went to USA and I got this pain and all, but some other histories are not relevant. We are supposed to politely avoid it. History tell us what type of the patient is that. Is it aggressive patient, relaxed patient, or type A patient, type B patient, or what are the treatment he took, whether he is taking one treatment or multiple treatment, and what is the behavior of injury. Usually, the researcher says that low back pain patient might have taken multiple treatment within a 1 year span of time. They have jumped from physiotherapy to Siddha to Ayurveda, Ayurveda to home traditional therapy to allopathy, they come back to the physiotherapy. So they have multiple treatments within 1 year. There was a research published by Western European journal. It says that low back pain patients, they have taken multiple treatment and multiple visit over the treatment. But sometimes patient may openly tell them, sir, I went to Siddha, I went to Ayurveda, I went to the local traditional treatment. Most of the time, patient may hide that. Like, so when you ask the patient how long this pain, the patient may say 1 week, but his husband may say, sir, 1 year. So there was a lot of confusion between the patient may think that when we say the reduced duration, the treatment will be very less. But actually, we are supposed to understand if this duration of the treatment also causes the duration of the injury may also give us a good idea about how the injury happens, what big the injury is. History of the present illness also we understand. We are supposed to look into past histories as well as the previous treatment taken and previous treatment effectiveness also. What are the treatment he took and how it was. Whether it's a physiotherapy also he took. What are the physiotherapy techniques he has taken for the back pain and how the back pain, whether it is reduced or not reduced also we are supposed to understand. Past medical history should include any major surgeries, accidents, allergies, or any other causes. Like sometimes the surgery or the accident may happen 2 years back, 3 years back. That because of the accident, the patient got pain and he was not able to not moving the limb and causes stiffness. But patient may not tell you that this pain was being there for 2 years. He may tell that, sir, I was not able to lift the shoulder for 2 months only. But actually it was almost 1 year, the patient was not able to do the movements. Same as allergies. Sometimes allergies, like there is a common example is the rashes. Rashes are like the skin diseases, which may also cause arthritic changes, right? So that under we have to ask the patient whether any medication he has taken or any prolonged medication was on. That has to be asked to the patients. Social history is very important to understand how he is living, and lifestyle of the patient is also very important. Family history is very, very important. Some of the conditions like arthritis, seronegative arthritis, seropositive arthritis, which has a common familial history, like ankylosis spondylitis may, if the father has got, maybe his son has got, or the rheumatoid arthritis, the mother has got, the daughter has got, or it comes to the family. So that family history is very, very important, especially for the arthritis. Other factors like how he sleeps, whether what type of mattress he is sleeping, how his workload is, what is the stress, and what are the recreational pursuits. So patient usually comes to, so I went for a holiday to my native, and my friends all together we played cricket. From that I got neck pain. From there I got strain. So the certain unaccustomed activities may cause a severe pain to the patient. That we have to understand. And we have to be very, very careful on irrelevant information. Sometimes patient may tell you all these unnecessary stories that has to be removed from the information, and you can tell them, sir, please, we will skip to the good part, right? So it should be done politely but firmly. Right. History collection should be done in order. So do not ask randomly the history and confuse the patient. So make it as a present history, present illness, past medical history, past family history, social history, economic history. So it should be in an order. Give the patient to describe the problem and limitation caused by the problem. That's very, very important. The patient has got shoulder pain, but what are the limitations he has got? Whether he was able to wear the shirt, he was able to undress it. That are the functional limitations we have to note it on, because that is the main important thing. We are supposed to focus on the patient. Clinicians should pay attention to find the functional outcome, expectation of the treatment. That's very, very important. So we have to identify what are the disabilities the patient has got and ask the questions easy to understand. Right? So very easy questions, patient might understand it. We have to ask. And we should not give a clue to the patient, or we should not lead the patient. For example, if you ask the patient, "Sir, I'm doing a movement, whether it increases pain." If you say increases pain, the patient says, "Yes, sir, it increases pain." Whereas you can say that, "Sir, I'm flexing your elbow, whether it alters the pain." So patient may think alter means either the pain reduces or increases. Patient may think, may give you any answer. But if you tell that, "Is it increasing your pain?" Patient may say, "Yes, sir, it is increasing my pain." So you should not give a lead to the patient. Ask one question at a time. So one question at a time, and get one answer for the question, and then move on to the other questions. Right? Do not poke with so many questions, and patient may confuse, and we may miss out important information. Right? Open-ended question for ask for narrative information. Like, "Sir, how long you have pain?" And the patient will say, "Sir, the pain was started like 2021, and I was sleeping on the," and all these stories was giving. Don't put on narrative information. Whereas closed-ended question for specific information. For like, "Sir, whether you have pain while lifting the shoulder in flexion or extension." So we are going to give you only one question we are asking, and you are going to get only the pain in flexion or extension. Either one or two, the patient will answer. But the open-ended question, patient may come and tell you all the stories, right? Right. Personal history includes, we have to ask about the smoking history, alcoholism, tobacco usage, etc. We have to ask the patient, and then we have to identify whether the patient, because sometimes alcoholism is one of the common causative factor for a avascular necrosis of the hip joint. So patient may have adult patient may have a sudden hip pain, and you do fibrosis, and patient got the hip arthritis. You can find out adult patient doesn't have arthritis, so pain in the hip joint. Maybe because of avascular necrosis. So we have to identify it is a common cause following alcoholism. So that we are supposed to ask to the patient. Social history: how is the living atmosphere? How many stairs the patient has to climb? What are the major recreation that we have to understand it? Because if the patient following a TKR, you say that do not climb many stairs, and the patient house is at the first floor, he is supposed to climb only 10 stairs. And you cannot say that, "Sir, please change your house." That is not possible for the patient. So we have to understand his living atmosphere. Sometimes you have to change the living atmosphere, depends on the patient's economical status, whether the patient was able to change it, or you can alter it based on the patient's status. Working atmosphere, job task, what is a job task also we have to identify. Economical, as they say that how well they spend for the new equipment. When you say that, "Sir, please break down all your stairs, we'll put a ramp," whether the patient is affordable to break the stairs and make the ramp, it comes around 2 lakhs money. Whether the patient was able to do that, or job modification. If you say that there's a patient with a severe neck pain and he's a writer, and you cannot say, "Sir, please stop writing and do the other job." That is not at all possible for a patient. So we have to look at the patient, whether he was able to do the job modification, whether he was able to do spend money for new equipment, new designing of the house, or we are advising the patient to buy 10 dumbbells. So whether the patient was able to buy the dumbbells in the house, that and all we have to look into the patient's economic history. Right. So far we have seen the demographic data in the subjective assessment. One is the demographic data, other one is the history. And now we are going to see the important part is the pain assessment. Right? Pain assessment is very, very important, because based on this assessment, we are going to confirm the diagnosis of the patient. Mostly we are able to confirm it by doing a pain assessment. First and foremost is you have to ask the site of the pain. Where you have pain, sir, where you have pain, you have neck pain, where you are able to locate it. Right side of the pain, is it right side or left side? Right? So usually acute pain, the patient was able to say, sir, I have severe pain on the tip of the shoulder. But in the chronic conditions, patient may have, say, have pain around the shoulder. So generalized pain will be seen in the chronic conditions, localized pain seen in the acute conditions. So we have to understand where the pain is and ask about which movement causes pain. So patient may say, I have flexion movement causes pain, abduction external rotation causes pain. So we have to be very careful on which movement causes pain. What are the frequencies of the pain, whether it is constant, periodic, episodic, or occasional. So sometimes when I sleep like this one, I am getting pain. Or when I lift any activity, I am getting pain. When I use the towel, I am getting pain. Or when I play racquetball, I am getting pain. So we have to ask which it is causing pain. So anytime I am having pain, sir, the shoulder pain is still also there, sir. When you are speaking also, I am getting pain. So it's a constant pain. We have to ask what type of the frequency is that. But usually acute pain, okay, this was given in the David Maggie, and he said that this acute pain is for 7 to 10 days. Subacute pain is for 10 days to 7 weeks, and the chronic pain is more than 7 weeks. Okay. Some examiners may ask you this question. So what is acute pain? What is subacute pain? What is chronic pain? And every therapist will give you different the days. Like acute pain is 2 days or 3 days is acute, subacute is 5 days. But it is all wrong. As per David Maggie, acute is 7 days to 10 weeks, 7 to 10 days. That is, a week is acute. And 1 week to 7 days, 7 days to 7 weeks is subacute. More than 7 weeks is chronic. Just remember like that. And we have to find out what structures and what are the pain are. Like muscle causes cramping and dull aching pain. If it's a ligament and joint capsule is dull aching pain. Nerve is a sharp shooting pain. Sympathetic nerve is a burning and pressure like sting aching. Bone is a deep nagging dull pain. Fracture is sharp, severe, intolerable, and vascular is throbbing and diffuse pain. So depends on the structures, the pain also differs. When the patient is telling that the pain is a deep boring pain, it's an intense pain. So I have pain like when I remove my tooth. So the pain is called as bone pain, or a pain is like lightening sensation. It's a nerve pain. So we have to understand what type of pain and what structures involved. So we have to ask the patient how the pain is, whether how you ask the patient to explain the pain he feels. Sir, pain is there, very dull pain. So it is purely a muscular. But pain is there, so severe pain is there, intolerable pain, maybe a bony pain, right, or a fracture. Another important thing in the assessment is we have to ask about which are the factors which increases the pain, which are the factors which reduces the pain. So what factors increases, what factors reduces. That's aggravating factors and relieving factors. What are either the movement may aggravate the pain or the rest may aggravate the pain sometimes. Usually patient may say that rest activity or the other postures or visceral functions may alter the pain cell. But sometimes viscera may involve. If the pain will be in all the days, so there is no relieving factors. Pain is all the day. I am trying to. Sometimes patient may come and tell like that. So we have to understand it. Right, morning pain with a stiffness that improves with the activity, usually chronic inflammation and edema. Right, early morning if the patient have a pain and stiffness, but when he does some activity, he does a knee movement, he does a hip movement, it reduces. So it is chronic inflammation. Usually this is arthritis, osteoarthritis. Osteoarthritis has also got morning pain and stiffness. Same like rheumatoid arthritis, but osteoarthritis, the stiffness and morning pain will dissolve within 10 to 20 minutes. But whereas in rheumatoid arthritis, morning pain and stiffness will be there. It resolves more than 30 minutes. Right. So usually morning patient complains of morning pain and indicates a chronic inflammation. Right. Same patients complains of pain at rest and pain that is worse in the beginning of activity. Like early morning, when I am keeping my foot down in the floor, I was not able to keep some severe pain in the heel area. Then that is a plantar fasciitis. That's acute inflammation, right? And the plantar fasciitis may also occur. So after 1 hour sitting, when I try to stand, I have severe pain, right? So that's the plantar fasciitis, acute inflammation, right? So like that history also we are able to identify it is this condition maybe. Pain or aching as the day progresses usually indicates congestion. So morning and I don't have any problem. But when I start walking, I'm getting pain. So maybe because of congestion of the joint. Pain is not affected by rest or activity. So pain, I said, I have pain full day, sir. There is no change in the pain. Pain is same when I sit and I do activity. When I rest also, the pain and I sleep also, I have same pain. That indicates a bone pain or an organic or systemic disorders like as cancer or disease in this one. Like a renal problem, patient have a back pain. So any movement, the patient will have same pain. Or a patient with a cancer in the abdomen, the pain in the back, whatever the movement the patient will do, every movement the patient have a pain. So it may be a visceral problem or maybe systematic disorder or bone problem, the pain will not reduces because of active also. Visceral problem sometimes affected by movement unless the movement compresses or stresses the structures. If you do the movement and which compresses the structure, the patient will relieve of the pain. Or if you press the abdomen and ask the patient whether the pain is relieved, sometimes patient may say, yes sir, my pain is relieved. Symptoms of peripheral nerve entrapment like carpal tunnel syndrome or thoracic outlet syndrome to be worse at night, right? So carpal tunnel syndrome patient says that, sir, morning and I don't have pain, but evening and night I'm getting severe pain in the fingers, severe pain in the ulnar border, severe pain in the medial border of the fingers. It may be a thoracic outlet syndrome or a carpal tunnel syndrome, right? So peripheral nerve entrapment. Chronic pain associated with multiple factors like fatigue or certain postures, like a computer operator sits with the forward head posture, so severe pain in the neck. So because of poor posture, the muscle goes for fatigue. At the end of the day, like early morning, he was okay, but when he starts typing with the forward head postures, and there will be severe pain in the neck. At the end of the day, he has got severe pain on the neck. And he lie down also, stayed with it because of muscle fatigue. The poor posture causes pain. Pain and cramping with prolonged walking may be because of spinal canal stenosis or lumbar spinal stenosis. Usually have a neurogenic intermittent claudication. Sometimes vascular problem is also there, circulatory intermittent claudication is not there. So if it is an intermittent claudication, a patient says that the pain is there sometimes, pain is disappear sometimes, pain is there sometimes, then you have to think about stenosis. Stenosis may occur because of bony problem. Stenosis may occur because of disc protrusion. Or stenosis may occur because of space occupied lesions like a tumors, right? Or following a trauma also, spinal canal stenosis occurs. Very important, you have to ask the patient about night pain. Sometimes patient has got severe pain in the night. Ask the patient whether it alters the sleep or not. If the patient says, yes sir, when I am lying in the bed, there was not there. But when I turn to the one side or lie on the shoulder, affected shoulder, my pain increases. So the pain was increases because of compression of the structures. Or the knee joint, when I lie down straight, there was no pain. But when I turn my knee joint, and I have got severe pain. So knee problem has got severe because of sudden movements of the knee joint. So we have to be very careful movement, questioning the patient when he is lying down. Intractable pain at the night may indicate serious pathology. Patient was not able to trace. So pain was there, but I was not able to identify where the pain is. That the pain was sometimes on the shoulder, sometimes on the elbow, sometimes on the wrist, but the whole upper limb was involved. Whole shoulder was involved, whole lower limb was involved. So maybe a tumor. Right, very important thing we have to ask, especially this is very useful. This slide is very useful to diagnose a low back pain, right? So if the patient have a pain, especially in the lumbar spine, and you have to ask two questions: whether pain is increased in sitting or pain is increased in standing. If the patient says that pain increase in sitting or bending forward, it is because of discal problem. If the patient says that pain is increased in standing and standing, then it is a facet problem. So intervertebral disc problem occurs in sitting because when you sit, there's a compression of the anterior side which pushes the disc posteriorly, which causes irritation of the nerve or irritation of the structures, causes aggravation of the symptoms. Same as bending forward also aggravates symptoms. Whereas facet joint pain, extension only causes pain, standing only causes pain. Forward bending, sitting will not cause pain because sitting in forward bending will relax the facet and it will not cause pain. So if a patient comes with a low back pain, just ask two questions: where the pain, when the pain occurs? Pain occurs in sitting or standing. The patient says pain is more in sitting, then it is a discal problem. If the patient says pain is more in standing, Then it is a facet point. Right. Very important thing apart from the pain scale, we have to ask about the mattress or the pillows used. Foam pillows often causes more problem in the person of cervical disorder because a pillow has bounce effect. So because of the feathers, improper pillow positioning, or too many pillows, 3 pillows, 4 pillows, we are watching TV by lying down on the pillows, which causes strain to the neck. Mattress also, if the patient is not having a hard mattress, if he is lying in a soft mattress or a poor mattress, then back pain is very common. Right? We have to ask about the mattress also. Very simple. If the patient says that pain is there when before lying down, it is because of some muscle structures. If the patient says pain is there after waking up from the bed, sorry, from the day full day I don't have pain, but when I sleep and wake up I am getting pain, then it is because of the pillow. If the patient says, sir, all the day I don't have pain, but early night and all I'm getting pain, it is because of the muscle fatigue that is walking is not there, poor posture. So when the patient says early morning pain, getting up from the bed is pain, then it is purely a poor positioning or poor pillows or poor mattress. The next important thing we have to ask is about peripheralization and centralization, whether the pain radiates down or coming back. Any movement which brings back the pain to the center, or which movement will produce downwards, right? So that number we are supposed to identify. Right. Apart from that common pain conditions, we are supposed to ask about the referred pain. Sometimes referred pain may be common in all the musculoskeletal conditions. When the patient has adhesive capsulitis, the pain may radiate to the forearm, right? The arm, sometimes to the forearm. So we think that pain is radiating, so it is a discal problem or a nerve injury. It is not right. Maybe the adhesive capsulitis may cause radiating pain. Same as tennis elbow patient with the tennis elbow may have pain in the forearm. That doesn't indicate it is a some nerve entrapment. May have a tennis elbow, may have spreads their pain. So these are called as referred pain. Pain that felt deeply, doesn't have boundaries and radiates segmentally without crossing. Usually the left shoulder pain, the patient complains of pain, we always ask the patient to check for his heart function, like echo scan or ECG. ECG has to be taken for identifying any left shoulder pain. Referred pain means that pain is felt at the site than other tissues because a referred site is applied by the same or adjacent nerve. Left shoulder pain may have occurs because of heart. Right shoulder pain may have occurs because of the liver functions. Right? Like how you will measure pain? Usually there are 2 tools to measure pain. One is the visual analog scale, which is the second picture is the visual analog scale. And the first picture is the numerical pain rating scale. So numerical pain rating scale where we can put 0 to 10, and where 0 is no pain and 10 is the worst pain and the 5 is the moderate pain. Whereas the visual analog scale, we are not going to put any marks. We just say that the 0 is no pain and in between is the moderate pain, and the last one is the pain is as bad as it is maximal pain. So most of the patient is comfortable with numerical pain rating scale where the patient was able to give some numbers. Sometimes we are also using the pictorial representation. These are emojis for measuring the pain. Like 0 is no pain, it's happy smile, and 10 is worst pain with a sad face. That also can be used. Mostly these emojis, pain scale is used by the nurses when they do nursing pain assessment. But physiotherapists also started, few hospitals have started implementing this emoji scale for pain measurement, because NIPH asking the hospitals to do the pain assessment as well as functional assessment. So most of the hospitals adopt this emoji like pain scale for the assessment. Right. So far we have completed the demographic data, the history, as well as the pain assessment. The subjective assessment is over. And now what we are going to look into is the objective assessment. We are going for the observations, we are going for the palpations, we are going for the examinations, right? So far what information, what we see here is the information which we are waiting from the patient. So the patient, whatever he tells, we get the information, we created, okay, patient may have this problem, right? But I'm sure the patient may have 80% of the problem, but not missing the 20% also. He may have this problem also, But I'm sure that 80% he has this problem only based on my clinical knowledge, based on anatomy knowledge, based on the history what he said. So my prediction is he has this pain, but I'm not avoiding this pain also. So that can be confirmed by doing a objective assessment, right? So we are going first is observation. Observation means just looking the patient, just observe the patient, stare the patient, and find out what the patient complains of. You have to observe it for visible defects, any defects in the part, functional deficits, abnormality of the alignment. Usually observations are done in the normal standing postures, when the patient stand and observe it. But observation usually starts from the waiting room. So when the patient comes here, you just ask the patient to wait, and then you just observe the patient, what condition he may have. Maybe a knee pain, if he's pressing the knee, you can say it is knee pain. If he's pressing the neck, he may have neck pain. You just observe the patient, how he is. And the second thing is observe the patient when he is walking. And patient should be unaware of that, because when you see the patient gait during aware, the patient may do a wrong gait or may voluntarily do some gait. Whereas if you are watching the patient unaware, patient may give a different picture. Okay, in observation, we are just observe the patient, do not touch the part, right? So we should not touch the patient, just observe the patient and identify what complaints he has. Unaware observation may give a different picture of the patient, especially when you observe the posture as well as the gait. So both you have to observe the patient without knowing him. So when you observe him, like he may have a duck walking gait, like remember gait and all, he knows that you are observing the patient clearly. Usually observation has to be done in the dominant eye, right? Everyone has to know how to find out the dominant eye. So you have to use your fingers and then identify which is your dominant eye and observe the patient with the dominant eye. And observation should be compared with both the sides. If the right limb is observed, look at the left limb. Both the sides, is it okay or not? Because sometimes we think that hey, muscle bulk is very less for this patient, but other side normal also is very low. Moderately is big. So we cannot say one side is less, other side is more. So we have to observe. Adequately address the patient and in a private assessment exam. If you are treating a female patient and a male therapist, please keep one attendant. Same goes for if you are treating a male patient and a female therapist, please keep one attendant so that it's a safety for both the patient as well as the therapist. The undressing is very, very important, because without removing the part, without removing the area, without visually looking at the joint, should not diagnose the condition. So I just share one example. When we are working in an outpatient department 20 years back, one of our colleague therapists was treating a male patient who has complaints of low back pain, and especially over his complaints of pain on the back pain and the hip region as well as in sacral region. And as a female therapist, she just palpated with his pants on, and when she palpated, she found out there is some strain in the SC joint, and she kept short rate as over 2 to 3 days. Unfortunately, one day I visited the department for another patient, and we discussed about this patient, and I just want the patient to remove the pant. And when I start removing the pant, and I was noticed the patient has some skin rashes, like a psoriatic kind of rashes, and asked, what is this, sir? And he says that, sir, I use a lot of public toilets, so that may be a rashes will be there. So usually for the skin disease or psoriasis, heat therapy is not indicated. So, but unfortunately, we have given 3 days of short radiotherapy to the patient, and there's a chance of spreading of the infection also. But later on, after that, we have changed our treatment and we have done some other treatment and settled the patient and then go. So, without looking the part, we may have a wrong diagnosis. So, observe the part which the patient complains. Right. The next part is the normal alignment. So, look at the patient's alignment. So, whether the patient's anteriorly is okay or posteriorly is okay. Anteriorly, the patient has made the body was any neck movement, abdominal neck movement. Look at the ear level, where is it? One ear level is higher, lower. Look at the chin, look at the nose, whether it is straight or curved or rotated. The shoulder is high shoulder, low shoulder, whether the hip is neutral or the height of the hip, or the patella is facing anteriorly or rotated patella, or the foot is facing anteriorly or rotated. That all will give a clear picture. Same goes for the posterior. When you see the buttock level, when you see the scapular movement level, when you see the calcaneum, And you can identify the Achilles tendon. You can identify it is a flat foot, that is calcaneum valgus, calcaneum varus, or the calf muscle is hypertrophy of the calf muscles, or buttock one side, buttock is weaker, other side is thicker, or the scapular levels or superior inferior scapular level. That will all give you different pictures. On the lateral side, so usually the lateral side you observe the patient with a forward hip posture, or a kyphotic posture, or lumbar lordosis, or the anterior the genu recurvatum is there. That all can be observed on the lateral side. Right? Observation will give a clear picture about the alignment of the patient. Look for any obvious deformities that make restricted range of motion, like flexion deformities. Very common in the knee joint. ONE, this flexion deformity is very common because of spasm or because of osteophyte formation. Flexion deformity is very common. When you observe the patient that the knee is not straight, there is some flexion of the knee joint, then you can find that there is a flexion deformity. When you attempt to extend it, patient complains of pain. Or malalignment, genu varum, bow legs, very common in ONE, or knock is very common in rheumatoid arthritis. So that are not very common, you have to identify it. Alteration in the shape, like this finger, minor fork deformity, or a fracture of the hip joint causes limb shortening. So when you observe it, and the patient is limb shortening, or the patient hand is a minor fork deformity, or the shoulder is a little bit lower than the normal level, then maybe a dislocation, maybe a wrist fractures, maybe hip fractures. Alteration in the relationship with the two articular structures, subluxation, dislocations are very common. So we have to look at that also. Deformities. We have three types of deformities: structural deformities, functional deformities, and dynamic deformities. Structural deformities are occurs because of there is some problem in the structures, that is in the bones, like torticollis. There is some problem in the muscle. The muscles are tightened, so the child comes with a one side deviated hip, or a fractures, or scoliosis, patient with a tilted one side, or kyphosis, excessive kyphosis. These are structural deformities which are not treated. Even if it is rest, also the deformity is present. Even activity also deformity is present. Functional deformities are deformities which occurs when you doing functions or during positions. Like the patient is absolutely normal, but when he walks, the patient will have scoliosis. The patient is absolutely normal. There is no flat foot, but when he stand up, the flat foot is there. But sitting, the arches will appear. So it's a flexible flat foot. So there's a functional deformity. A dynamic deformity occurs because of muscle. So in muscle contraction only, the deformity will be there. If muscle is not contracted, deformity will not be there. Look for the bony contours as well as the muscle contours. Whether the bone is normal, is the patella is looking normal, or the tibia is normal, hip joint is normal, any symmetrical or any deviation is there. Look for the toes, whether toes are straight or deviated one side, deviated inners. Look for the soft tissue contractions, where muscle wasting, visible muscle wasting. You can obviously see wasting of muscles in ill-treated stroke patients or polio patients. There is a vast wasting of the muscles. So we have to identify the muscle wasting also. Limb positioning, equal or symmetric. Compare the limb size. Like so, the picture shows that the patient with the baby with the CTV, congenital talipes varus. So you have to look at the limb position and identify it. And you can see here the down picture is the patient having a dinner fork deformity. There's a fracture, there's a pulley fracture. That's a lower, not the radius. So by observing this position, we are able to identify, okay, there is some problem in the foot, there is some problem in the wrist. So it is not normal. There is some abnormality is there, right? So ask the patient that yes, sir, the fracture was happened, but after that I appeared POP and it was like that only. It was an old fracture from 10 years. So that after this many years, the patient have a dinner fork deformity lives with them. So that are now we have to observe. So you have to observe for the shape, you have to observe for the color of the limb, atrophy, because the nails are bluish color indicates discoloration, increased circulation. If it is a high red in color, it is increased circulation. Inflammation is also there. So just observe it and identify it. So sometimes with clubbing also you have to identify it. Right. The skin observations include the color of the skin, the texture of the skin, ecchymosis or bruising. So ecchymosis may be because of any injuries or a fall. Bruising may be because of milder injuries. That are all we have to keep the patient and identify what causes the pain. Tropical changes like peripheral nerve injury, like shiny skin, hair loss, breakdown in the skin also to be noted. Next, observe the skin for psoriasis, cyanosis, or redness. You can see in the picture, it is not very clear, but the patient has got mild psoriasis. Like a patient with a juvenile rheumatoid arthritis, patient may have butterfly rashes in their face. When you observe the patient with the butterfly rashes in the face, you can say that the patient has a rheumatoid arthritis or systemic lupus erythematosus (SLE). Right? So just observe the skin conditions, and we are able to diagnose the patient may have the disease. May have the disease. Injuries to the skin like lacerations, scars, and blisters and all has to be observed. External noise, very important. We have to find out whether when the patient is walking, when the patient is doing any movement, whether you are able to hear any sounds like crepitus or snapping. We have to find out. Crepitus occurs because of damage to the cartilage. Snapping occurs because of tendon rupture over the bone part. Right? Look at the attitude of the patient, whether the patient is apprehensive, whether the patient is calm, or type A patient very aggressive, or the patient is sir, it's already time late, sir, I want to go, hurry patient. We have to look at the patient. Patient restless or depressed patient. Facial expression, whether the patient is with severe pain, discomfort, or patient with the sleep lacking, so because of the irritated tension. We have to observe that. That also may cause lot of changes in the treatment. When the patient is in severe discomfort, if you give mild treatment, also patient may feel better, and patient will feel better. Sometimes patient will not respond to any treatment because his attitude itself doesn't like to get some treatment. I say, I just want 1 week leave. I want off from the office. So just give me this treatment. So sometimes patient may say that. Right. So far we have seen observation. What we observe it without touching the patient, we just observe it and identify it. Now we are going to touch the patient and find out what the patient has got. That is palpation. And we have to palpate it and find out. So palpation is important assessment technique, and make sure that the part which you are going to do palpation is relaxed. So make the patient relax and do palpation. First and foremost thing what we do is observation of the temperature. So feel the temperature on the posterior part of the hand and then identify it. If the temperature is higher or lower, if it is higher, indicates increased circulation or inflammations, acute injury, there's increased warmth is there. If it is a cold because of decreased circulation or cyanosis or any injury to the arteries, it causes coldness. So we have to compare the warmth with the patient. That's the first and foremost. Before doing any assessment, first you have to do the temperature. Compare with both the sides, compare with the other places also. Acute phase joint will be warmer and tender. Warm may also due to infections, swelling, or after exercises, or may be covered with the bandage. Sometimes patients covered with the bandage. When they remove the clip bandage and you palpate it, they may feel warm. Or the patient may walk for a longer distance in the hot sun. Sir, I just walked 1 kilometer from the sun to reach the hospital. So that time when you palpate it, sometimes patient may got warmer. So that is not considered as a warm. So we have to wait for that patient to cool down and then observe. Right. Second important thing is tissue tension. Palpate the tissues, whether it is effusion, that is any swelling in the patient, or spasm, whether the spasm is a protective spasm or the patient spasm is occurs because of abnormality in the tone. So muscle tone like spasticity, rigidity, flaccidity, and all has to observe. So muscle tone is observation is done very easily by passive movements. Just give some passive movements to the part and then identify it, right? Whether identify the tone of the muscle. If it is smoothly, or if it is too tight or too rigid, too spasm, that we are able to identify. Abdominal structures, palpate this, palpate the bony areas, bony margins, muscle structures also you have to palpate and find out whether the shape and size is similar to the other areas. So myositis aspirations, when you palpate, you can find out some hard the brachioradialis muscle, right? Hard bone structures, which is abnormal in the brachioradialis muscle, can be palpated. Or osteophyte formation in the knee joint. When compared to the other knee, you can palpate there is some projections at the knee joint. So there is a osteophyte formation that can also be palpated. Swelling. Usually swelling comes soon after injury is spread. Swelling comes after 8 to 24 hours. Usually the patient will say, when the swelling occurs, say yesterday night I fall down from the bike. But that time I don't have any swelling. I just have pain and then I kept eyes and the pain was normal. But early morning I got severe pain and there was swelling. So that is because of synovial fluid effusion. Whereas when I get a fall yesterday night, immediately I got swelling. That is because of blood swelling. So blood swelling is hard, tense, feeling warm, whereas synovial swelling is woggy, spongy feeling. When you press it, it is spongy. And we have hard swelling also, like bone, when you palpate it is very hard, tough and dry is callus formation, leathery thickening is chronic, soft fluctuation is acute, and thick and slow moving is pitting edema. So pitting edema occurs because of renal problem, because of cardiac problem, or because of pulmonary problem. We have to identify what causes the pitting edema. So we have to be very careful on doing this palpation and find out what type of swelling the patient has. Important is the tenderness. That is what we are going to do as a musculoskeletal physiotherapist. We have to palpate the muscle, palpate the area, and find out what type of tenderness the patient has. Apply a firm pressure to the point, firm pressure to the joint. Pressure should be always given with the care. Tell the patient that you are going to palpate it, because without telling the patient may have severe pain. Like grade 1 is a patient complains of pain. Grade 2, when you are palpated, patient complains pain. The pain is there. That is grade 1. Patient pain and says, sir, pain is there, right? That's grade 2. Patient's complains, winces and withdraws the. When you palpate, sir, pain, and he withdraws the joint. When the grade 4 is patient will not allow you to touch. When you don't touch, sir, don't touch, it will be more pain. So we have to find out what type of tenderness the patient has got. Grade 1, grade 2, grade 3, or grade 4. Sometimes patient is apprehensive to the pain. So even if you before touching it, I will get pain. So you have to calm the patient, relax the patient, speak to the patient, and slowly touch the point. Okay, feel for the pulses, tremors, and fasciculations. Fasciculations are results of a contraction of the number of muscles innervated by the single motor action. The contractions are very localized, usually subconscious. Patient is not able to, but there will be contraction of the fingers, contraction of the wrist will be there. Do not involve the whole muscle. Only the part of the muscle is also just a small movement of the fingers. The tremor is alternate involuntary contraction of alternate agonis antagonis. There is sudden movement of the whole joint, or rhythmic movement of the whole joint. It's called as tremors. And we have to look at the pulses also. So pulse is radial pulse or the dorsalis pedis pulse has to be palpated to find out any circulating insufficiency is there. Should also test for the rhythm, strength, and also be noted. Palpation should also look into the skin. If it is the skin is feel dry or excessive moisture of the skin is there, we have to observe. Usually, gouty arthritis, the skin tend to be dry, whereas septic arthritis, the skin is moist. So we have to look into the skin whether it is dry, and dry may be a gouty arthritis, or moisture may be septic arthritis. We have to look into that. Nervous patients, sometimes patient is nervous and they have sweating in the palm, sweating in the foot also will be there. Hyperhidrosis is a common condition where the patient get increased sweating in the fingers, increased sweating in the dorsal of the foot. Sensation, whether it is a hypersensation or dimness sensation or absence of sensation also be noted. Using a knee hammer, the brushes or the pin, you can note the sensation. Or if you don't have anything, you can in a clinic, you can use a bike key or a car key and then find out the sensation. Because mostly the nerve lesions or the patient with diabetic has got decreased sensations. Or sometimes very rarely the patient with leprosy has got decreased sensation, but leprosy is totally eradicated. So that is not a very less conditions only we are supposed to see. But nowadays it's very common sensory loss is seen with the diabetic patient and patient with severe nerve compression, nerve injury patients. So other thing is crepitus. You have to palpate the joint and ask the patient to move. You can feel the crepitus. So sometimes soft fine crepitus is an acute articular cartilage damages, that is early degeneration of the joint. Coarse grafting is a damaged articular cartilages or menisci along with the bone also damaged. Commonly seen in severe OA. Patient usually neglect the acute condition but get damaged and the articular cartilage is worn off and then coarse grating will be there. Apart from the snapping, also you can find out. So snapping in the shoulder, snapping in the hip also. If you palpate it, then your patient will ask the patient to do movement, then you can find some snapping will be there. So that also is a abnormal sensation. Right. So palpation, the very important is you have to palpate for the tenderness, palpate whether the bone is normal or abnormal, and palpate for the pulses, whether the pulse is normal, there is any fasciculations, any tremors. So these are very three important points we are supposed to do in the palpation. And the fourth is the temperatures. Right? When we move into the examinations, right? So first and foremost, we have to understand what are the principles of examination. Firstly, you have to tell the patient what you are going to do. Without telling the patient, do not lift the hand, do not bend the elbow. So tell the patient, sir, I am going to do some finger movement. I am going to do some elbow movement. Please bear with that. Any pain is there, please tell me. Test the normal side first, uninvolved side. Okay, sir comes with the both the pain, what to do? Test the side which is having less pain. When the right hand has left pain, so start doing the right hand, then do the left hand. But if both the hands are paining, then do which hand has got less pain, then do the side first. First do active movements, then passive movements, then the sister isometric. First ask the patient to do active movement, then you can do some passive movements, passively you can do, then isometric contraction also do that. Always painful movement are done at the last, right? So do the movement which are painful at the last, because a patient comes with a P adhesive capsulitis and he says that the abduction is painful. And when you do the first movement of abduction, patient will get painful. Sir, pain. And whatever movement you do, so when you do flexion, when you do extension, when you do rotation, the patient say pain. So you do not know which movement causes pain. So you got to ask the patient which movement causes pain and do the movement last. And find out other movement is okay or not. Avoid overpressure or apply overpressure with care. When you are doing a flexion, a patient was able to do only 120, still you can push the shoulder, but do it with the care. Repeat movement or sustained posture if the history indicates. Patient says that intermittent claudication or the carpal tunnel syndrome only by holding the paper for longer duration. Do it for 5 times, like Roos test. Do it for 10 contractions, 20 contractions, do it for 30 minutes. Then only you are 30 seconds. Then only you are able to identify it. Other important principle is do resistor isometric in the resting position of the joint. Joint has to be kept in the resting position, do not do it in the closed back position or in the other contracted position, right? So the muscle will contract normally. With the passive movements and ligament testing, both the degree and quality of the infields and opening are very important. So when you do a passive movement, when you do a ligament testing, we are supposed to look into the how much amount of the movement that the joint is separated. When you do an anterior test for the ACL injury, feel the quality of the movement, how much the anterior ligament is allowing the bone to come out. So that is very important, because when the ligament testing, when you increase the test with the stress, there will be more movement, indicates there's a rupture of ligament or severe injury to the ligament. When doing myotome testing, hold the joint, hold the muscle for 5 seconds at least, so that the symptom may reappear. Very important. Tell the patient sometimes it may increase pain. So I'm doing some movement in the shoulder. Sometimes the pain may increases. So please be careful and do not blame it. Otherwise, patient says that, sir, I have very mild pain. I went to the XYZ clinic and he do some movement and my pain was severe. I was not able to lift the shoulder. So this XYZ therapist is waste therapist. Don't go there. So we have to give a clear idea about the patient that when I do the movement, sometimes pain may there. Maintain dignity of the patient, that is very important. That will give you dignity of the therapist also. Unless bilateral movement is occurred, first test the normal side first. That is the correct side first. Active range of motion is not full. Overpressure is applied with extreme care, right? So if the patient is not able to lift the full range of motion, apply overpressure with extreme care. Do not apply forcefully. Each active, passive, and resisted exercises must be done with several times or held for certain amount of time to see whether symptoms are increased or decreased. Resisted isometrics are done with joint in a neutral or resting position, so this just the inner tissue is minimal. Myotome, as I told you, it has to be kept for 5 seconds. Very important, limb length should be measured for complaints of leg pain or back pain, because sometimes abnormal limb length shortening of the limb length may cause the pain in the back or pain in the hip or pain in the knee joint. That has to be measured. So 2 types of limb length measurement is there. true limb length and apparent limb length. True limb length is from ASIS to medial malleolus. Apparent limb length is from sternum to medial malleolus or the umbilicus to the medial malleolus. Sometimes we can do part measurement also. So ASIS to the lateral malleolus, the lateral condyle of the femur, from the lateral condyle of the femur to the lateral malleolus. The part measurement can also be done. If you suspect there is a shortening of the femur or shortening of the tibia, then you can do part measurement. Muscle girth, very important. I just want to share it. Muscle girth measurement should be done in the maximum bulk, and you have to measure appropriately. Because one time I went as an examiner to one university, one college, and I asked the patient and asked the student to measure. That's the model is there, and he is measuring a muscle bulk and for the thigh bulk. He measured. So right side is 25, left side is 18. I was literally shocked because he's a normal individual, and I was seeing he doesn't have a visible wasting also. How there was 8 centimeter differences? That is not possible. When I asked probably 1 or 2.5 centimeters itself, it's okay, because sometimes the right is overactive, left is less active, we can consider. But 5 centimeters, 6 centimeters, 10 centimeters is not at all possible for normal use. So when I asked him how he measured, he just wrapped a place on the right side, he just wrapped a place on the left side, and he measured it. That is a wrong kind of measurement. When you are measuring, you have to take some point to the measurement, like ASIS to 10 centimeters of the below the thigh, then mark it. The same ASIS to 10 centimeters on the left side also. When you do right side, same length is on the left side also. From there, you have to mark the measurement and then find out. For the shoulder, if you are measuring from the tip of the shoulder to the biceps, you have to measure 10 centimeters, 20 centimeters. Or from the auricular process, go upwards. Or auricular process, go downwards for the measuring forward. And muscle girth, when we are measuring it, and we are supposed to write as arm girth, forearm girth, thigh girth, or the calf girth. There is no measurement like biceps girth, quadriceps girth, hamstring girth. That is a wrong way of writing it. Refer is necessary, very, very important. You have to refer the patient if the patient is you are not able to identify it, or you find that there is something suspect. It is not really musculoskeletal. Maybe visceral problem, maybe tumor, you have to refer. Right. Very important part in the assessment part is the in-feel. In-feel is the feeling of the examiner when you do a movement. When I do a passive movement of the joint and the movement reaches, and I feel some movement is in there, that is in-feel. Right. So in-feels will come on practice only. As a new therapist, when you do that, you don't find that okay, this is in-feel, that is in-feel. In-feel, you have to do practice and you identify the difference between the in-feel. When you go and do the assessment of in-feel with a lot of patients, different patients, you are able to identify and create your own knowledge on the in-feels, right? Do not believe that if I am saying that this is muscle spasm, do not believe it. You have to do it and identify it. Yes, this is muscle spasm, right? Everyone has a individual perception on the in-feel. Passive range of motion assessment examiners are apply overpressure the end and find out what is the in-feel. We have 3 normal in-feel and 7 abnormal in-feels. Like 3 normal in-feel is bone to bone, elbow extension. When you extend the elbow further, there will be no movement. When you do further movement, is a breakdown of the bone occurs. So that is called as a normal in-feel. Soft tissue approximation, knee flexion. When you flex the knee, still you are able to flex the knee. Same as elbow biceps. Biceps bulk and the forearm bulk restrict the movement, but still we are able to bend it. That is soft tissue approximation. Or tissue stretch, ankle dorsiflexion or shoulder abduction, external rotation. This is normal external rotation. When you apply little stretch also, the patient will produce this movement. Right? That is a normal feel. Bone to bone, soft tissue approximation and tissue stretch. What is the abdominal in-feels? Early muscle spasm, that is protective spasm following injury. That is abdominal in-feel. Late muscle spasm because of pain. So do not break the spasm. Because spasm is mostly protective only. So when you try to break the spasm, you are going to cause more pain to the patient. So slowly relax the spasm. Hard capsula is in the frozen shoulder. Patient with the frozen shoulder, you can do the movement. Further, there will be no movement. Patient was not able to do abduction also or external rotation also. Soft capsule like synovitis, soft tissue edema. Bone to bone osteopathy, very commonly you can find out in the OA. Any patient, the way when you do the movement of knee flexion, you are able to identify the soft tissue or the osteophyte formation. Extension also causes restriction of the movement. Empty block you can see in the subacromial bursitis or spinky block. Meniscal injury, the movement of knee is not smooth. It will cause jerky movement. That is a spinky block. These are the abnormal end fields. Still, I am telling you, these end fields are abnormal. When you do with the many patients, you are going to identify the end fields, and you have to create your own perception of the end fields. Right, same as capsular pattern. So mostly the joint are surrounded by the capsule, and each and every capsule has got different patterns. And the movement restriction occurs, and that pattern is called as capsular pattern. Right, so that is called as capsulitis. So usually it occurs in the shoulder. We call it as adhesive capsulitis. Before that, we call it as a periarthritic shoulder. But later on, the researchers have said that there is no inflammatory changes occurs in the shoulder joint. It is a capsular tightness. So the capsular problem is there. So it is called adhesive capsulitis. So this capsular tightness may occur because of muscle problem, may occur because of tightness in the capsule, may occur because of abnormal shoulder movements or abnormal muscle bone movements, or because of osteophyte, or because of positional faults, biomechanical faults, may cause capsular tightness. For example, I am telling you the capsular pattern for shoulder joint is lateral rotation, abduction, and medial rotation. So first movement affected in the adhesive capsulitis is lateral rotation. The second movement is abduction. Patient lateral rotation was affected because of the affected lateral rotation. Patient was not able to abduct the shoulder. Other than that, the mid rotation is also affected. Right. Very important is assisted isometrics. You have to do the movement in the last because it may causes pain to the patient. So this type of movement is asking the patient to be a strong, static, voluntary muscle contraction and used to determine whether the contractile tissue is at the fault, whether there is any soft tissue problem in the area. That's why we are doing the assisted isometrics. These are the principles which are described by Janda et al. Right. The patient is asked to contract the muscle as strongly as possible by examiner giving resistance. Right. So I ask the patient to flex the biceps and give a resistance to the biceps. Then identify how much the patient are putting effort to produce a movement. So this is done if the muscle power is more than 3. If it is less than 3, we have to go for MRC grading or muscle power assessment. Right. Medical muscle response grading or muscle power assessment is the only thing we have to do. Right. Resistor isometric, we have got 4 classic patterns. First one is movement that is strong and pain-free. So if the patient was able to do movement which is strong and pain-free, there is no lesion in the contractile muscle or nerve. It's not the source of pain. Maybe some other structures may be involved in psychological also. Movement that is strong and painful. Okay, patient is very strong, but patient has in pain. So lesion in the muscle or tendon, grade 1, grade 2 injuries, like muscle strain, ligament strain is there. Patient was able to do the movement, but the pain is there. So it is a muscle or tendon problem. Okay. Movement is weak and painful. Patient was not able to do the movement and very painful. Severe lesion, maybe joint fractures or joint lesions, severe degenerations. Movement is weak and pain-free. So movement was not able to do, but pain-free. There is no pain. So total rupture of the muscle, grade 3 strain. Total rupture of the ligament. Movement was able to do, but the patient movement is weak and pain-free. Or some neurological involvement. So there is no movement and no pain also. Like this drop. There is no movement. Is there pain-free also? So these are the 4 isometric contractions which was described by Janda. Movement that is strong and pain-free, strong and painful, weak and pain-free, weak and painful. And if all the movements of the joint are painful, so any moment you do, I are in pain. So that is because of fatigue, emotional hypersensitivity, or emotional problem. Maybe psychological problem is the common cause. Some patient comes with a psychological problem. They say any moment is getting painful. Wherever you touch, the patient will say pain. Right. And the very important part of the exam is reflexes. We have to see superficial reflexes, plantar and gluteal, or deep tendon reflexes, biceps, lateral axis. Usually, these reflex testing are very important if the patient has any radiating symptoms or nerve impingements. If you find the patient have a brachial neuralgia or sciatica, the musculoskeletal part, we have to do it. In addition to that, if you are doing a examination of the region, just check the deep reflex is okay to rule out whether the nerve involvement is there or not. Okay, so reflex testing 0 is absent. You know this very well. 1 is diminished, 2 is average, 3 is exaggerated, 4 is clonus, and very risky. Right. The important part of the assessment in the examination is joint play. Joint play is the accessory movements which is happening inside the joint. These accessory movements are very important. We can also call this anatomical movement. These movements are very important to produce a physiological movement. Physiological movement is a range of motion. These accessory movements cannot be diagnosed, cannot be measured. Whereas physiological movement can be measured. Physiological movement is when I lift my shoulder, you are able to measure my shoulder. You can say it is 180 degrees or 120 degrees of the shoulder flexion. But the 120 degrees are achieved by the movement which happens inside the joint. That is gliding, sliding, rotations, compression, distraction. These joint movements cannot be measured. These are called as accessory movements. Any problem in the accessory movements may also affect the normal range of motion. I have gliding problem because of tightness or because of bone alignment or biomechanical problem. My joint is not working properly. Then the joint will not move properly. My physiological range of motion will be restricted. Right? So accessory movement cannot be done on the voluntary. So it is an involuntary only. We have to and find out. Joint dysfunction signifies a loss of joint plane movement. We have Bennell's rule for the joint plane testing. First and foremost, patient should be relaxed and supported fully. So make the patient relaxed. Not only the patient, the examiner also should be relaxed and have a comfortable grasp. Should evaluate one joint at each time. One movement should be examined at each time. The affected side should be tested first. First test the affected side, unaffected side, then test the affected side. The articular surfaces should be stabilized. For example, you are going to test my shoulder. The movement between the glenoid as well as the head of the humerus, we have to be very cautious that the glenoid cavity is at the rest and only glide the head of the humerus to find out whether the head of the humerus is gliding up or downwards or anterior posterior. Right? Movements must be normal, not force. You don't give excessive force to this movement. And if the patient complains pain or the movement is not correct, abnormal, or movement is not within the right position, don't do the movement. Right? So we have to follow these rules when we are going to test the joint play. And when we test the joint play, also we are producing manual therapy movements like gliding movements, which was described by Mulligan's as well as described by the Maitland, which we can do anterior posterior gliding or inferior gliding. That also produces a treatment effect also. So all the movements, when you do a joint play should be done with a relaxed position or loose back position of the joint. Right? Every joint has got loose back position as well as closed back position. Closed back position is the position where there is no further movement is there. For example, shoulder extension abduction is the closed back position. When you do further movement, there will be shoulder bone dislocation. Elbow extension is the closed back position. When you do further movement, there will be fracture occurs there. That is a closed back position. So do not do movement in the closed back position. Always do the movement in the resting position or the relaxed position. That is called the loose back position also. Where the structures, the muscles, the joint structures are in the relaxed position. Very important part of the assessment is the functional assessment. We have to evaluate the patient function. What are the difficulties of the patient? What are the things the patient was able to do? What are things the patient was not able to do? What are the disabilities of the patient has to be assessed clearly. Because when we are able to achieve all these functional improvement, the patient will be very happy. For example, we always treat like that. If a patient is a housewife, like 50-year-old lady housewife comes with a shoulder pain, our main motto is to lift the shoulder without pain, not the full range of motion, at least lift the functional range, like 90 degrees to 120 degrees is okay for the lady to wear her upper body dressing and to do any household chores. Whereas for athlete with a 20-year-old comes with a shoulder pain, he needs 180 degrees of shoulder movement because his function is different. Whereas housewife function is different. We have to find out what function, what disability, and what activity he is going to do. Based on that, we have to plan our management. Right. Very important part, and we have only last few slides. I'm going to complete it. The special tests. Special tests are the important tests. Every physiotherapist who completed the final year should know at least 2 special tests for each and every condition. Although the special test will not give a confirmatory diagnosis. Special test will may tell you that this condition, this is the condition. Okay, if you are doing a shoulder movement and say it looks like a biceps tendonitis, but it doesn't rule out the supraspinatus tendonitis or other condition also. Not necessarily to the other condition, maybe shoulder arthritis or maybe neck pain also, but it is purely a tendinitis, right? So special tests, although strongly suggest a particular disease or a condition, when they yield positive result, do not necessarily rule out the disease or condition when they yield negative results. Okay, when they yield a negative result, do not rule out. Always take a concern with them, right? But mostly the special test will give a positive result only when you can confirm the diagnosis. So confirm a tentative diagnosis. Based on the history, I think the patient has got biceps tendonitis. Based on the observations, based on the palpation, I found that there is a only problem in the biceps. And when you do a Gerson test, when you do a speed test and find out yes, a pain is there with the biceps tendonitis. Okay, to confirm the tentative diagnosis, we can do a special test and find out. To make differential diagnosis also, I think it is biceps tendonitis. But I can also do for the supraspinatus, I can also do for the rotator cuff, I can also do for the subscapularis, I can also do for the cervical pain, I can also do for the thoracic outlet syndrome. So I can differentiate and identify, okay, all these are negative. So this is only the positive. So my diagnosis may be correct. Biceps tendonitis only. Differentiate between the structure. It is a muscle problem, ligament problem, nerve problem, or a vascular problem. You can find out. To understand unusual signs. So like Bruce test, you can find out there's a very pain or tenderness or patient have numbness in the fingers. That are all they're able to understand by doing a special test. To unravel difficult signs and symptoms, that also special test helps to find out, helps to tell you to this the test which helps to identify it. Okay, last part of today's class is about investigation procedure. Although we are not well involved in that, but we should have a basic knowledge. Like any orthopedic procedures, they will have a plain X-ray because X-rays are ready available, relatively cheap, and provide good anatomical resolutions. Sometimes they will go for arthrography when the patient was not able to identify the joint space or identify the contrast material. But nowadays, they are going for a CT scan, which gives a clear. Nowadays, 128 CT scan, 256 CT scan, 512 CT scan will slice every joint, every minute of micro part of the joint and tell you whether there's a fracture is there or whether there's any trauma to the tissue. See, MRI will also tell you clearly about the soft tissue abnormalities. Radionuclear scanning is done for any tumors. Any case of tumors, they are not able to understand. Diagnostic ultrasound is for the muscles. And last slide is the lab test. We usually do the orthopedician first test advised to do is the ESR. When you identify ESR is elevated, then they say there is some inflammatory problem is there. We are supposed to understand the potassium level, calcium level, uric acid level, because uric acid is very important in rheumatoid arthritis. Rose-Waller test, the latex application test is commonly done for the rheumatoid arthritis. Sinus fluid examination also we just do. But nowadays it is very easy. Most of the lab, the lab test results comes with the normal values. We as a therapist, we are able to identify, compare between the normal and abnormal, and we can say the patient will have. Sometimes patient may come with the test report and ask you to read out and tell them. So you can give them a clear idea about that. This is a synovial fluid examination. Appearance of the synovial fluid is clear yellow, is a non-inflammatory state. Cloudy is inflammatory arthritis. Thick exudate is a septic arthritis. Hemorrhagic is a trauma or bleeding. Right? So synovial fluid examination we do for severe arthritis or seronegative, seropositive arthritis. As there is severe swelling in the joint, they remove the synovial fluid and go for the analysis. So that's it for the today's session. And as a good therapist, what we are supposed to do is we have to give away for a clear investigation procedures that is very, very much needed before going for a diagnosis, before going for a treatment. The investigation procedures or the assessment is very important to confirm the diagnosis. Why the assessment is important? Because when you want to treat a patient, give a complete treatment, not a symptomatic management, give a treatment for the causative factor. That's why we are doing assessment. I can thank everyone, and I have taken all the notes and the references from orthopedic physical assessment, David Maggie. He has got enormous write-up on the assessment, and you can find each joint assessment also very clearly. Right, so thank you, Chandra. And it's yours now. Thank you very much.
Thank you, sir. Thank you so much for a wonderful session. And I request those who are in Zoom now.
It's not audible, Chandra.
Sir, am I not audible? Hello.
No, it's audible.
Oh, welcome, Vincent, sir. Maybe kindly check with the sir, Arun, sir. Can you speak for me? Vincent, sir?
Yeah, it's audible. It's
yeah,
clear.
okay.
Yeah.
Yeah. Arun, sir, it is audible, sir. Kindly check.
Thanks. I was not able to hear.
Or remove that phone at least. Remove the connection, sir. Check the connection or remove the connection. Okay, meantime, I request our participants to post your queries, and those who are in our Zoom chat, kindly type your queries here. In the chat, you can type. Thank you, Vaibhav and Kirtana. Yes, I know it's audible. Meantime, I will make a call for our resource person.
Yeah, it's audible.
Yes, sir. Yeah, welcome back, sir. Yes, sir. So, if you have any doubts,
any questions? Yeah, please.
Any questions from Zoom chat? I will be checking our YouTube also now. I request all our YouTube viewers to post your queries. I will be reading the questions here.
You can type the questions in the Zoom chat also.
Any questions from our Zoom participants? I can see Tamal Shelvi madam, Vincent sir.
Sir, Arun sir, Vincent here, sir. Sir, your mic is muted. Good evening, sir. How are you? Nice presentation. Sorry, right from beginning I didn't join, but in between I have joined, sir. Okay. Thank you. Thank you, sir.
Thank you.
Sir, I think no questions, sir. You have given a clear idea about musculoskeletal assessment. Though everybody knows about it, those who are graduated or doing their fourth year or doing their post-graduation, they know it. It will be like a refreshing point of view for them. And there were so many extra points they have collected from this webinar, I think so. And there were no questions in our YouTube chat also. Everybody is giving compliments for you. Good lecture, sir. Thank you. Very informative. It is an extremely good informative and enlightened with assessment session. And thanks for your valuable session. Nice presentation. Very well explained.
There's one question.
Yes, sir.
One question. Person is sensitive. He has mild pain and complains several things. If the person is sensitive,
and he have mild pain, complaints, severe pain.
Severe or several pain?
So okay. Maybe high griva you are there.
Oh, very simple. Like if the patient is highly sensitive, we have to deal with that patient very carefully only, because sometimes, like I'll say example, if it is a sports person, when you do a palpation, patient will be able to resist the pain, and he'll say no pain, even though if you give your 100% effort on palpation. But some patient, when you touch it, he'll say grade 4 tenderness. So like that patient, we have to deal very carefully. Better we can first start some treatment to console the patient, and then we can start doing the treatment rather than going for the assessment and then treatment. Sometimes we have to cut short our assessment and start giving some treatment, make the patient clearly understand that the pain was little bit lesser, and then we can start doing your assessment. Because the whole assessment, when we do it in a clinical setup, we can see only 1 or 2 patients in the whole day. So we have to capture the assessment, depends on the patient what you are getting. There is no hard and fast rules in the assessment, right? There is nothing is there. You can do it on your own base.
Yes, sir. There is
More
another
questions,
more
sir.
question, sir, from Lavish Sharan.
Crepitus is normal abnormal. Crepitus is not abnormal only because there is a degeneration changes like crepitus occurs because of articular cartilage damage. So if you find a crepitus, it is abnormal. Any sound created in the body is abnormal. It is a lung sound. Abnormal lung sounds is abnormal only. Any joint sound is also abnormal. So the crepitus may be mild crepitus or coarse crepitus, depends on the degeneration of the articular cartilages.
Yes, sir.
Very good question.
Yes, sir. No questions in YouTube, sir. And there are a lot of
Saturday evening, sir, we can't do anything. Everyone are feeling sleepy, right?
yes, sir. Sir, another one. A few questions are coming now. Yeah, I think we can.
Patella maltracking may lead to crepitus. Certainly, patella maltracking lead to crepitus. Abnormal movement of the patella lead to crepitus, especially in the chondromalacia patella. You are able to see that. Even this maltracking may result in may cause degeneration in the later stage. And maltracking is very common in young individuals also, like school-going individuals, college individuals also. They have got maltracking of the patella. So we have to give a clear assessment, not only from the knee joint but also from the ankle joint, to find out how the ankle is. If there is any problem in the ankle, like inverted calcaneum may also predisposes the patella for more damage. So we have to be very careful on assessment of not only the knee joint but also the ankle joint is very important. I thank you. Question.
Kirtana, that is from
Another question from Pramod. Pain assessment grading on VAS versus NPR, which is more clinically relevant. As I told you, clinically relevant, this patient will easily understand through NPRS only, because NPRS has got numbers. That's what I said. Nowadays we started using the emojis. Okay, so smile faces, happy faces, sad faces, and all, where the patient was easily able to understand and tell that emojis. VAS scale, when you are going to teach the patient what is VAS scale and making the patient to understand the VAS scale and asking the patient to touch number, this here, and that is very difficult. So as a clinical therapist, use NPRs. That is the best way to assess.
So from YouTube, from Dr. Varsha Singh. Sir, one patient came to me. He has not pain, but he starts walking on his toes in between while working. What is the cause?
Maybe tightness of the muscles.
Right. Yeah.
We have to identify the muscle tightness. We have to go for good calf stretching for these patients, and it's purely a muscular problem, not a body problem. Muscle tightness is results because of prolonged sitting posture. The muscle may got tightness, so he may start walking on the toes.
Yes, sir. Another one more question is from Jack Asil. How do we differentiate between ligament injury and tendon injury?
Using special test only, we have to identify how the movement of the ligament when you are testing. For example, if it's ACL ligament or a patellar tendon. So ACL ligament has got different tests, and the patellar tendon rupture has got different tests. So depends on the test only we are able to identify it. And the mechanism of injury is also there. Depends on the mechanism, we can find out what structures they got involved.
Yes, sir. Thank you, sir. And any other questions from our Zoom participants?
So
No
how
more
to
questions.
differentiate end-field and capsular pattern? As I told you, it is very purely your perception. So you have to do with many patients to identify what type of end-field is there. Is it normal end-field? Normal end-field is okay, because we know that these are the normal end-fields. But abnormal end-fields, like this is a springy block, this is a muscular spasm. You have to work on the patient, and you have to create your own way of perceiving that this is the end-field, this is not normal end-field, this is the abnormal end-field. As I will give you an example, like when we learn Maitland manual therapy, they say that it is grade 1, grade 2, grade 3, grade 4. When I asked my teacher who taught me Maitland, he said that that is your own perception. When you give you grade 1, you think it is a grade 1, but I see that that is not grade 1, that is grade 3. So what is your perception? You create on your own and find out this is the grade 1, this is grade 2, grade 3. Same as that for the end-fields and the capsular pattern, you create on your own. So the capsular pattern, how the capsule will be there in each and every joint is given in the David Maggie. Bigger column is there in the David Maggie. Just read through it. And each and every joint has got a different set of capsular type. And if the pain or if the patient has that set of problem is there, that set of tightness is there, that indicates it is a capsular tightness.
Yes, sir. Thank you, sir. Thank you so much. Tamil Selvi madam, kindly we need another session about special tests. We will be, yes, sure, we will be considering it. And yes, no questions in YouTube. So lastly, I would like to thank you very much, sir. And I'm so happy that Dr. Vincent is here. He's my professor too. Thanks for joining with us. And yeah,
thank you, sir. Thank you.
And I thank all our participants from different parts of the globe who took time to register and attend this online session. And I thank Ms. Tuna for wonderful help making registrations links. And maybe tonight we will be checking the attendance and we will be releasing the certificates within a day. Thank you, sir. Thank you so much for a wonderful session, sir.
Thank you, Duna madam. Thank you. See you. Bye.
Yeah. Bye-bye. Good night, all of you. Yes, sir.